the training or do not submit services using EVV for January 1st, 2021, services and beyond, providers will not get paid until the EVV system is used. So make sure that you're taking that training through that system so that you can submit those services properly. The use of EVV for home health services will be implemented in 2023. This system will help provide real-time alerts when a provider is late or misses a medically necessary service included in a member's service plan. So it's very, very important. Again, the system will help provide real-time alerts. CareBridge offers a downloadable mobile application through Android or iOS, and caregivers can use on their own devices. So that will be extremely helpful if you're out in the field taking care of those folks. This will be extremely helpful, be able to put it on your own device. Now, CareBridge EVV platform is set up to streamline the claiming process. The mobile application and the web-based platform are configured to note when information is not present that is required for payment. So, for example, when a provider exports claims for payment, the system will assess the visits selected for potential claiming issues as defined by the MCO. Now, here are some resources for you. CareBridge is your best resource for all of the information regarding getting signed on, how to use the system, any questions that you might have. So this information will be extremely helpful for you moving forward. Again, all of this information will be put out on our website in about 2 to 4 weeks. You can take a screenshot of this if you'd like. Otherwise, it is on our Iowa Medicaid website. All of this information will be out there. All you have to do is type in EVV and this information will be provided to you and you'll be able to search from there. You can also register. I believe that there is one more training scheduled. You can register for the training with CareBridge. And EVV training is available for all individual and agency CDAC providers, as well as CCO employees that provide personal care services. Again, more resources for you. So here's where you can submit your questions and your issues. And here's some additional questions and facts that have already been provided out there. Now let's move into crossover and secondary claims. There's an informational letter 2157, and it is a payment reminder for crossover claims. Under there, this is for services covered under the Iowa Medicaid state plan. The new methodology will consider the amount Medicaid would have paid had it been the sole payer. The amount Medicaid pays will be the lesser of the full Medicare coinsurance and deductible, or the difference between the Medicare payment and the Medicaid rate. Now, if the reimbursement paid by Medicare exceeds the Medicaid allowable payment, Medicaid will pay nothing additional on that claim. This change will treat Medicare the same as Medicaid treats other types of primary insurance. For Medicare services which are not otherwise covered by the Iowa Medicaid state plan, IME will use the special rate or method to calculate the amount Medicaid would have paid for that service. Now, the coordination of benefits applies to Medicaid members who have coverage with more than one healthcare plan. By federal law, All other available third-party resources, except for Medicare or Medicaid, hold a liability or TPL, third-party liability, and must meet their legal obligation to pay claims before Medicaid pays the care of an individual eligible for Medicaid. Therefore, Medicaid is generally payer of the last resort. Now, Medicaid does not participate in the COB in the same way as other insurers. Medicaid is never primary payer and will only make payments up to the Medicaid allowable amount. Essentially, the total amount paid between the primary plan and the Medicaid should not exceed 100% of the total Medicaid allowable amount. Now, here are some common billing errors or crossover claims. Incorrect filing indicator for Medicare claims, so watch for these. Medicare paid amount and patient responsibility is absent. And if you do encounter any billing issues related to this, please reach out, and we have the IME provider outreach email listed for you here. Regarding third-party liability, there's an informational letter, 2131, that is very beneficial, and that would be a great resource for you. ELVS no longer provide CPL verification or third-party liability verification for members assigned to an MCO or dental PHP, MCOs, and dental PHPs will provide the third-party liability information for their members. So this is definitely something to keep in mind. Providers should report third-party liability leads or changes for members' health insurance or dental coverage to the members assigned MCO or dental PHAP. So if you do know of a third party that is involved with your member, make sure that IME knows about it and make sure that the MCOs know about it. And that way, claims can be processed correctly with that third-party liability information. IME is not the source of truth for third-party liability. Providers need to go through the MCO's dental plans to verify the coverage and report the changes to them. The fee-for-service member third-party liability verification continue to use ELVS or Eligibility and Verification Information System. Third-party liability leads or changes for members in FFS should be reported using Form 470-5445. Insurance update fee for service members. The time to process the third-party liability is 60 business days. Now we're going to go into Health Home Learning Collaborative. And I believe that we have Pamela Lester on the line with us. Pamela, are you there?
Yep, I'm here. Can you hear me okay?
Yep.
All right, good deal. Thank you guys for verifying. So my name is Pam Lester. You can see my
Mike, can
title.
you hear me?
We can hear Pam.
All right. So I
Hi,
am,
Pam.
hello. I am the program specialist, and I manage both health home programs in Iowa Medicaid.
Pam, are you able to hear me?
Yep, I can hear you. All right.
Maria, we can all
Thanks, Sean. Can you go back one slide? There you go. All right. So these slides, the title is because we have spent some time working with both health home programs to have a better understanding of the other one, and I'll go into detail here in just a little bit. So these slides are from that presentation. Maria, could you go to the next slide? Sean, can you have her switch to the next slide?
Mike, are you able to hear me? I'm asking for Mike Kitzman.
I can hear you, Maria. Maria, can you hear me?
Maria, can you go to the next slide for me?
Hey, Maria, what are you looking for from Mike?
Don, are you able to hear me?
Yep, can you hear us? Can you hear
Are you
us?
able to hear me?
Yep, I can hear you. Can you hear us?
I can hear you.
Can you take the headphones and unplug those? Can you hear us now? No, we can't hear you.
You can't hear me?
Oh, now I can. Maria, I just could when you said that. Yep.
Okay, now I can hear you.
Okay.
Throughout the presentation, were you able to hear?
Yeah, we heard you, no problem there. Pam was
Okay.
asking if you could go to the next slide.
Oh, okay. All right, now I can hear everybody. Thank you for that. I appreciate it.
All right, thank you. So both of these state plan amendments are out of the 2703 amendment out of the Affordable Care Act. We have two state plan amendments. One is a primary care spa that was approved in 2012, and a serious mental illness state plan amendment that focuses on adult and children with a serious emotional disturbance or serious persistent mental illness. And when we do a new state plan amendment through the health home program, we're allowed to draw down 90/10 federal match for a total of 8 quarters. And then after those 8 quarters, it goes to that regular match. So it really helps give us those federal dollars to really be able to build these programs. So of course we've exhausted the 8 quarters quite a while ago. Next slide, please. Eligible plan types. Members that qualify to be enrolled in the health home program must have the full Medicaid benefits. They can have medically exempt, so they're IHOP, but they become medically exempt. They qualify. Full Medicare and Medicaid. So if they are receiving, so if we're paying for the Medicare premiums, that wouldn't be considered a full Medicare Medicaid. And then it's really actually easier to talk about those programs that are not eligible to be enrolled for the chronic or the integrated health home program. Iowa Health and Wellness, Hawkeye Family Planning, WIMBY, SLIMBY, and presumptive eligible members. Next slide, please. So here is a side-by-side to help give a better visual of the 2 different programs. The first is the type of provider that provides the service. So typically the integrated health home is a community mental health center, but not in all cases, but do need to meet these requirements as a provider to be able to be enrolled in the integrated health home program. We do accept applications and agreements for the integrated health home. So if you happen to fall under one of these provider types, you could certainly enroll in the health home program, the integrated health home program. The chronic condition health home is a primary care provider. A lot of times there's confusion between home health and the health home program. And so this is not home care, it's a primary care provider. Then each of them have a little bit unique care team. The integrated health home has a nurse care manager, a social worker that's usually a care coordinator, peer and family peer support specialist. The chronic condition health home has a designated provider, so usually a doctor, DOD. It can be a nurse practitioner, physician assistant, especially if you think about some of those rural health centers that don't have a primary care provider practicing in those. So that's an example of where that would fit in. A designated care coordinator, a health coach, and clinical support staff. The chronic condition doesn't have a peer support specialist, so that's one of the things that is a little bit different in that. And then services. It's really, both of them are exactly the same. The federal government requires that the health home program provides 6 specific health home services, and we'll talk about those in just a minute. And the unique thing with the integrated health home is they also provide the case management for habilitation and children's mental health waiver. Members can be enrolled in the integrated health home or chronic. I'm getting a lot of feedback. Is there somebody that could put themselves on mute? I think it's the AB 549090.
So we've got about 415 people on the call right now. And even if one person doesn't have themselves on mute, the echo could be what's affecting Pam's audio. So if you want to make sure that you're on mute if you're already not.
Thank you.
Sorry.
Oh, that's quite all right. Go back just a little bit. One of the last things I want to point out is a member can be enrolled in a health home and also be on a waiver. So there's an additional care coordination piece to coordinating with the case manager, the community-based case manager that is managing that waiver. It'd be like another specialist that we want to make sure that the health homes are coordinating with all of the specialists, all the providers that are involved in that member's care. Who is eligible to be enrolled in a health home? We talked about that they have to have full Medicaid, and they can be full Medicare, Medicaid. They can also be full private insurance and full Medicaid, as long as they have full Medicaid. But also there are different conditions that require that member to be enrolled. So first, do they have the right program type? The second is, do they have the right health conditions? So an integrated health home, it's an adult with a serious mental illness with a severe functional impairment, and then a child with a serious emotional disturbance with a functional impairment. That diagnosis must come from a mental health professional, and that functional impairment through an assessment. The chronic condition health home has to have one and at risk for another of one of these listed: mental health, substance use disorder, or asthma, diabetes, heart disease, overweight or obese, hypertension, COPD, or back pain. So as long as they have diagnosis from a primary care provider of one of these, and there's documentation in the record that they're at risk for another. For example, they have hypertension and they have a family history of diabetes, that would qualify the member. Or they're overweight and they have a family history of diabetes, it would qualify. It needs to be documented in the record. Next slide. So I want to talk just a minute about those 6 health home services that the federal government requires that every health home state plan amendment has identified. Comprehensive care management. So do they have a comprehensive whole person assessment? Do they have a comprehensive plan on how they're going to coordinate and work with that member to improve their care? Then the next piece is coordinating their care, providing health promotion. So what, based on their conditions, their age, gender, what are those things that we need to make sure that they're doing for preventative care or to manage those chronic conditions? And then comprehensive transitional care. So anytime a member changes a level of care, the health home should be involved in coordinating to make sure that that's a smooth transition, that we're doing a medication reconciliation. We're making sure that the member has transitioned successfully to the other level of care. Typically, you think of this as maybe from an inpatient stay back to home. Could include an ER visit and making sure that they transition back to home. Making sure that they've got their medications, they understand their medications. You know, that's one of those big things that is very important, to make sure that they're taking the right medications when they go home, especially when sometimes in the hospital they're put on a formulary. We don't want them to take the formulary and the medication that they were taking at home. Patient and family support. So making sure that we provide them any support that they need, whether it's for the integrated health home, that peer support or that health coach working with them to help them with their goals and engaging those different supports. And then refer to community and social support. So making sure that if any community needs, whether there's a referral to a peer support group somewhere, things like that. Maybe there's some community resources through the public health agency that would be appropriate for those folks enrolled in the program. Must have choice. So the member has to choose to be enrolled in the health home program. That's done through a verbal consent. The health home must explain what the program is about, what the expectations are from the health home provider, the member expectations, what they should expect to get, how it should work, and also what it looks like if they choose not to be enrolled in the program again, or they would like to switch health home. So sometimes we do see members switch from the integrated health home to the chronic condition health home. An example is we once had a schizophrenic mother who was a high-risk pregnancy. Both the health home and integrated health home worked together, but based on the member's choice and what was going on with the member, they worked together to help manage. Now they can only be enrolled in one, but they did a great job at still supporting the member, whether they were enrolled with them or not, in transitioning the member as appropriate. All right, next slide. Oh, that is it for me. If you have any questions, please put it in the chat and I can address those.
Thank you, Pam. I really appreciate that. And thank you all for keeping your phones on mute. That is extremely beneficial. It worked out really nicely. So again, thank you, Pam. So we'll go ahead and move into the telehealth and COVID-19 information. Now, I do want to let you know that this is just a big overview. IME is constantly adapting and changing to our world. Therefore, any of the latest information on telehealth and COVID-19 will be updated on informational letters. So I would encourage you, whatever questions that you have related to telehealth or COVID-19, please do refer to the informational letters that are out there. And again, as soon as IME knows anything, we put out that information to you as quickly as we possibly can, because in our world today, everything is constantly changing, and we're again adapting to those changes and trying to get you the information so that you can make the best decisions for your members and for the billing systems that are out there as well. So I just wanted to make sure that everybody knows where to find these at. So here are some of the informational letters that have been out already. Again, updates are constantly going out. So I would encourage you to go out and sign up for informational letters because those will be a great resource for you. Now, the next slide here is we're going to be talking about the originating site is the location of a Medicaid member at the time of service and is provided via telecommunications system. Excuse me. The offices of physicians or provider types 2 and 3 and other practitioners, psychologists, social workers, behavioral health providers, habilitation service providers, and excuse me, nurses as well. Hospitals, critical access hospitals, community mental health centers, federal qualified health centers, rural health clinics, area education agencies, local education agencies. Originating sites is a paid facility fee. The facility fee is an amount paid to the originating site for hosting the patient during the telehealth visit. Now, the originating site would charge the facility fee using Healthcare Common Procedure Coding System. And this would be code Q3014. The federally qualified health center and rural health clinics would not bill Q3014 as a separate service because reimbursement for the related costs would occur through the annual cost settlement process. Now, a distant site is the location of a physician or practitioner at the time the service is furnished via telecommunications system. The distant site practitioners submit claims for telehealth services using the appropriate current procedure terminology, CPT codes, or HCPCS codes. Practitioners at the distant site who can furnish and receive payment for telehealth services include physicians, nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, federally qualified health centers, certified registered nurse anesthesiasts, clinical psychologists, clinical social workers, behavioral health service providers, licensed independent social workers, licensed master social workers, licensed marital and family therapists, licensed mental health counselors, or certified alcohol and drug counselors. The expanded telehealth services will be in effect until at least the end of federal public health emergency, which as of today's date, this is what we're aware of, which is January 20th, 2021. However, we know that that could change. But at this point, the expanded telehealth services will be in effect until then. The department is currently reviewing the continuation of expanded telehealth services beyond this date. Here are the informational letters that do refer to EDI Support Services Gateway transition. So let's go into more of the EDISS. Is working with Transition All Iowa Medicaid Managed Care Organization encounter transactions, fee-for-service web portal users, and all existing Iowa Medicaid web portal functionality out of the legacy EDI gateway. Now, EDISS will not require any additional forms or re-registration for this transaction. All existing submitters and their associated transactions will be migrated into the new gateway via automated processes. EDISS will require submitters who utilize the legacy web portal to verify their EDISS Connect account, profile, fax number, and email address. The web portal user-specific changes. Web portal connectivity for batch and real-time transactions will continue to be supported in the new processing solution. Now, the core functionality and output to submitters are the same. The new user guides to assist with navigating the updated portal. Use the existing URL that is listed here. That has not changed. Let's move on to EFT. The reference informational letter for EFT is 2167. All EFT change requests must be submitted via a secure upload using the Iowa Medicaid Portal Access System, or the IMPA system, rather than by fax or email. So make sure you're using IMPA for the EFT change request. And here's the information for the change request registration. So here's the link, and then you click on register new account link at the top of the page. Complete the registration form. Your password must be at least 8 characters and include 1 uppercase character, 1 lowercase character, 1 digit, and 1 special character. Enter the verification words and click the create link. When you receive the congratulations message, click OK. Log into IMPA. When you log in for the first time, you will be required to answer 3 security questions before proceeding. Under the main menu, hover over File, Upload File, click on Document to IME. In the document types drop-down menu, select Provider EFT. Follow the instructions, and on the screen in the blue box, once you have logged in to IMPA, you will find 2 options. If you already have the EFT form and your voided check or bank letter as one PDF, you can bypass the merge and open PDF step and go directly to the select button. Select document on your PC. Next, click the Upload button. Your uploaded document will appear in the History table, and that's how you know that it has been sent to IME for processing. If you do not already have the EFT form and your voided check or bank letter merged as one document, follow the steps on the screen to merge into one PDF. Note, all of your documents must be saved in a location on your local PC. After the documents are merged and saved to your local PC, you are ready to upload. Click Select button to open the saved merged document. Click Upload button to send the document to IME. Now, this process can only be used for the submission of an EFT change. The initial EFT request must be submitted with the enrollment application ticket during initial enrollment. When using this process, please use the following practices to ensure your EFT is received as intended. The EFT form can be found on the IMPA landing page under Featured Functionality. This will be the most up-to-date version. Submission of an outdated version will slow the process down. When the document is uploaded to the IME, you will see the history of uploaded documents on your screen in a table. Document size is limited to 20 megabytes. All EFT changes are verified prior to processing. Any non-EFT documents submitted through this process will be discarded and will not reach the intended destination. If you have questions or need help submitting your organization's EFT form, please contact Iowa Medicaid Provider Services Unit at IME Provider Services at dhs.state.ia.us. IME Provider Services is your best resource. Now we're heading into another section here, and this is regarding our informational letters. You can find all of this information on IL 2113. The IME publishes provider bulletins called ILs, informational letters, that are necessary to clarify and explain new and existing programs and policies. ILs are an important cross-reference for any new policy changes that have been implemented but are not yet reflected in the published provider manual. Now, ILs are organized on the department's website by the year of publication and then in descending numerical order. The web page where ILs are posted, changed, has a new look and search options. Because of this, any internet favorites or bookmarks you had for the department's ILs will need to be updated. So again, here's a link for that. To access previous ILs, users can type in a keyword or phrase in the search bar or choose one or more of a series of suggested choices under the following drop-down menus: provider type, provider topic, or program. Now, to access the search, you click on the arrow next to the search button. New IL webpage will display a search bar with the latest 10 published ILs underneath. Again, more details will be provided in future informational letters. Okay, so we have come to the end of IME's presentation. And again, keep typing in those questions in your chat box. So next we'll go ahead and we will go to our MCO, AmeriGroup, to have them conduct their presentation.
Good morning, Maria. This is Sarah Lynn. I will be making our first presentation.
Thank you.
If I can ask you to stop sharing your screen, I will share mine.
Got it. Thank you.
You're welcome. Okay. Get to the right one here. Here we go. Good morning. My name is Sarah Lynn Heston, and I am PSO or Provider Solutions Manager for AmeriGroup Iowa. I work specifically with large hospital systems, but help out in other areas. And AmeriGroup would like to thank Iowa Medicaid for allowing us to join the program today. Our first virtual, and as we all know, converting to being virtual in all of our daily works has been sometimes a little bit of a strain for us, but we will get there. I just realized I got to turn off, hold on, I got to turn off my, make sure I'm on do not disturb on my link messages, or I'm going to be inundated with things. There we go. Sorry about that, guys. So, got a few things that we would like to talk to you about from AmeriGroup. Updated things that are going on and a little bit of notifications that we've received recently. Some of you may already know this, some of you may not, but effective January 1st, 2001, AmeriGroup will offer a special dual needs program. This is the AmeriVantage Dual Coordination. It is considered a DSNP program here in Iowa. This dual coordination plan will be available in 18 counties of Iowa at this point in time. There are plans for expansion later on, but right now we are doing that for 18 counties. Individuals who enroll in the AmeriVantage Dual Coordination will be able to select one of the 9 services offered in the Everyday Extras package that we have available at no extra cost. Members should consult their evidence of coverage document for specific details as to what additional benefits might be available. We have a heading on our public website that will explain all of this program for any providers that may be interested. We also have it available on our member website, and we ask that you review the heading for any additional questions. We continue to do coordination of value-based programs for all of our provider types. We are really into medical.
This is Stan. How may I help you?
If I can ask everyone to please mute their lines, I would appreciate it. Thank you. We are heavily into the medical providers for value-based programs. And we are working on a couple of programs for our nursing facilities, our long-term care, LTSS services, and for our BH services. And basically the value-based programs are, we try to get some extra dollars to our quality providers that are serving our members in an appropriate or an above level way. We want our members to get every single benefit that is available to them and to have top quality care. And in order to do that, we like to work with our providers that are in our network or contracted with us and give them some additional benefits that they did not think that they might be available. So there are a couple of new things coming up, and I'll talk about them just in a little bit later. We have a provider bulletin email blast that is getting ready to post onto the website and availability. We are in the process of updating our website platform. We are also in the process of doing provider credentialing and rostering via the Availity portal website. That program is still in effect, and I have not heard an expected completion date, but I do know it's moving forward. One of the other things that we've had a lot of questions about that we want to call everybody's attention to is the pharmacy provider change for vaccines. There is an informational letter, and we'll talk about that later in the presentation too. But remember that pharmacists can now deliver vaccines, but in order to do that, if the only contract that you have with AmeriGroup is through IngenioRx, you need to make for positive that you get contracted with AmeriGroup also in order to get paid appropriately for those vaccines. We have some changes in our utilization management group. Avastin has moved to the non-preferred, as everyone knows, and we are quickly working on that. And there are substitute drugs that are considered now preferred according to the BDL from Iowa Medicaid. Our inhaled nitric oxide policy has been posted, and during inpatient stays, we will now be reviewing for medical necessity on those. And remember that the NDC codes requirements for physician administered drugs has been put into place, and that is also in a provider bulletin out on our website. For those that asked, or for those providers that ask a lot of questions about our availability enhancements, remember that within the past year, we have increased the bandwidth for medical documentation to be submitted directly on the availability portal. We have found that that has really helped with the ease of losing medical documentations and getting them reviewed in an appropriate format. Also remember that our claims and our reconsiderations are all done on the availability platform too. All right, so I want to talk a little bit about the AmeriGroup website. So remember, we have two websites available. The one that is shown here right now, providers.amerigroup.com/IA. This is our public website. Anyone can get to this. There is no requirement of a sign-on or any kind of a password in order to get this. You will notice over on the left-hand side, we have a category in this green box here that says provider resources and documents. And that's really where you're going to find a huge amount of the day-to-day information that you are needing in order to work. Our provider manual, as you can see, is also on that same public website, a link to it. And we just uploaded or are in the process of completing a new upload of the revision of that provider manual from changes that we have done in the past few months. And that should be going in shortly. I want to make the announcement that the website update that I talked about just a little bit. Now, this is not the Iowa website. The Iowa website is going to look very, very similar to this. It is in process. We had hoped to have it done January 1st. It may be a little bit of a delay, but from the meeting that I had earlier or at the end of last week, sounds to me like it should probably be in effect by about February. It's really much better organized, and I think it's a much more interactive, user-friendly platform than what we have had in the past. And one of the things that I'm extremely excited about, because I run into this all the time, is there is now going to be a search button on our website for our providers in order to find out if you're looking for a medical policy, say about Avastin, you can do a search and find all the connections for that drug within that site. I think that's probably one of the things that was bothering me the most on our previous platform, is that I couldn't do a search either, and it took me time to find things. And I think the providers are going to find that to be extremely beneficial. Remember that back in August of 2018, we moved to availability for submitting provider disputes. We have found that that has really worked very beneficial for our providers. We are continuing to have both reconsiderations and appeals there, and you can submit both levels through a review. You can attach documentation that is needed. If you just submit a claim and you get a notice that they can't even process the claim until they get a little bit of additional documentation, you can go out and you can process or attach that right directly to our provider in availability, into our provider correspondence area. And that documentation will then be directed to the individual that was asking for it. This has really been extremely helpful in the fact that it's reducing paperwork and the use of paper getting this documentation back and forth. Remember also, from your availability, you can go out and you can find a work list of disputes submitted, disputes requiring additional information, and your finalized disputes. So it kind of gives you a very clean snapshot of what is out there and what is going on, what we might be waiting for, or what additional information you think that you might want to send to us. Through the public website, that is how you get to your availability. Now remember, availability is our secure website. You will have to have a sign-on. You will have to have a password in order to get it. Every single provider has a higher level individual that is assigned to the account. It's someone in your office that kind of controls who is allowed access to availability. Because remember, from availability, you can get to claims, you can get to payment disputes, you can get to prior authorization requests, you can get to interactive care reviews, Everything can be gotten through the Availity portal. So you are required there to register and to only access with your appropriate sign-on. Remember that we have a number of services within AmeriGroup that do require prior authorization. Again, from the public website, in the green box, you will see under quick tools here, there is the pre-certification lookup tool. An example of what that tool looks like is shown here on the right-hand side. For all of our CPT and HCPCS codes, if you will input that into this box here, we give the indication of whether a prior authorization is required or not. And descriptions. It also will explain if we have a couple of, or we have AIM that works with us, not necessarily a couple. We have AIM that also does some of our services for authorizations, and that Pluto tool will identify who is handling that prior authorization. Remember that all inpatient services require prior authorization. And also there are certain behavioral services that also require pre-certification. And on that website, on the left-hand side where you see this Pluto box, it will give you the rev codes and the DRGs, I think it is, that are appropriate for BH that will always require a pre-certification. Oh, I skipped one there, sorry about that. I think I missed one too, but oh, okay. There we go. So on our website, public website, we also have provider notices and bulletins. It is in a blue box in the upper left-hand side of the current website, and will have its own heading when it comes into the new website platform. There have been such bulletins such as effective November 20th, hospice providers must submit the MPI of the residing nursing facility in box 77. If you have further questions about that, please see that provider bulletin. Also, we are doing a transportation vendor change for the Iowa market. We currently, as of October 1st, are using Access to Care as our NEMT vendor for those services. And as Maria talked about in her presentation, electronic visit verification process and training is also shown. The new training that is coming up will be on November 20th, I believe. And so please watch the website. Remember that having to use EVV is going to be effective on January 1st. Also on the public website is our COVID news and resources. They're called out under a separate heading. As we all know, staying up to date on the COVID information and directions is extremely beneficial for all of our members and our providers. So we felt that it was necessary to pull that information out into a separate heading and available quickly for our providers to use. Another huge thing that we put in this past year is the AmeriGroup Iowa System Configuration Updates. This is also shown under the provider resources and documents, that green box on the right or left-hand side of the website. And it is in the first drop-down box. On that system configuration, we talk about what is currently known issues that are configuration issues within our system that we are working to correct. Wanted to give a quick listing of some recently completed projects so that everyone knows what we are working on right now. We had focused internal audits and education on claims to ensure accuracy and improve specialized handling of Iowa Health Link only covered services for HCBS, for PDN, and for child medical services. We recently completed a project for the rural health clinics and the FQHCs of modification of, sorry, I'm getting overlapped by one of my boxes here. Modification for claims edit, and this is to ensure the proper lesser of processing. I know Maria talked about a lot of paying up to the lesser amount when it comes to Medicare claims, and AmeriGroup has been having some issues that we have been overpaying on RHCs and FQHCs, and that correction of the system was done around the 1st of October. Another correction that was just completed within the system for the RHCs and the FQHCs is we are updating the place of service 2, 32, and 31 to process the claims at the encounter rate of T1015. That went into effect about October 15th, and I know that some of the claims are still working on processing those. So if you work with FQHCs and RHCs, you'll probably be getting some notifications from us. We have also completed the project where supplies and DMEs in nursing facilities has been completed within the system. And these are for those services that are a limited set of products. We are paying according to Medicaid rules and not Medicare any longer. So on your MUEs, we are making for positive that we are processing those appropriately for Medicaid policies. If you are interested in seeing what current projects are going on, and I always recommend to providers, they look here before they call the reps to see if by chance there is anything that is already out there that is a known factor that could help them. That is shown at this link here. Again, as Maria said, all of our presentations will be available all on our website and on Iowa Medicaid's. So don't worry about copying that link down quickly. We'll make sure we provide it to you. When you look at the system configuration updates button, this is just a sample. It's a couple weeks old, so things have changed from here, but I just wanted to let you know the things that we are talking about. So providers have come to us that on the home health services that are not covered by a primary carrier. We need to make for positive that we are processing those according to what Iowa Medicaid is doing. And as you can see in our notification, we identify when the issue was identified, the status of it, whether it's in process, whether it's being put into effect in the system, or where it's at this point in time. We talk about the providers that are affected by it and the number of providers that we have noticed that are impacted. So we are looking at right now that on this one, there was a short-term fix that was put into effect on August 13th. We're hoping that the ongoing proactive claims reprocessing is going to be done on December 22nd. Understand that this process or this spreadsheet is posted once a week to our website. I think it goes on like late Friday afternoon, is usually there on Monday morning. It is a week behind because of the posting in the time frames. It will give you a status of what was done last week. But I know that I have had a number of providers say that this is extremely beneficial for them to be able to go out to see what is really looking in. If they know that we're in the middle of a project and when an approximate completion date is, they tend to send those claims to the side and focus on other things because it works out better for them not to invest their time in something they already know we're working on. So that changes weekly. As Maria talked about, the electronic visit verification, we will be using CareBridge, just like Iowa Total Care, and that will go into effect January 1st of 2021. Remember that this is a requirement, and in order to do that, we need to have our providers who are going to be using this program registered and ready to go. The final stakeholders meeting will be held on December 2nd. And we'll hopefully have recordings available on the Iowa Medicaid website. I believe that I just saw a posting that we have another training coming out November 20th. We'll get that and make for positive. We put that in the chat for you. Sorry, it's not showing up on mine here. So credentialing. Currently, America Group does credentialing through FQHC. And that is really about the only option for us unless you send in a full application. We do access applications from CAQH and can gather information from there. So if you already participate with CAQH and have completed your online application, all you have to do is authorize AmeriGroup to access your credentialing information. We are in the process of putting another option into effect, and that is credentialing and rostering directly through Availity. It will be loaded in. That program will direct those rostering informations, address changes, provider ads, anything that might happen there will go directly into our APDO, which is our AmeriGroup provider data organization, and they manage all of credentialing information, listings within facets, and it'll go directly into them. The nice thing about that is our reps have a tendency to get very busy working on some claims projects, and we are hoping that just like when we put in Availity into process for claims, that we will see a decrease in the response time back to providers to get those submissions handled. So that we will, of course, continue to work directly with that department as that happens. But I believe that that's scheduled to go into effect sometime in this early spring. So don't be surprised if you see information on that, and that should be coming out soon. Before I get to vendor updates, there was a couple of things that I forgot to mention, and we've got a couple of new programs, as I said on that first slide. One of the big things that I think is going to be great for everyone is AmeriGroup is going to start an email blast program for our provider bulletins, very similar to what Iowa Medicaid does with informational letters. We just posted that option out on the website, and it is a quick form for you to fill out, register your email address, identify what provider you are from, and we will put you on an email blast list. So from now on, when provider bulletins come out, you will be able to get a copy of that email blast directly. I know one of the things that we were running into is we did these provider bulletins via fax blasts previously. And when you work with, as an example, a large hospital system, we may only have one fax number on our record where there are multiple departments that need to get a copy of this. So you'll be able to register under your like group MPI in order to get these bulletins to come into your office directly. I think that's going to be a huge thing for everyone. And then one of the other things that's going on, and I forgot to mention it when we were back working on Pluto, is there's a new item that just hit the website, and it was probably about Thursday or Friday that it hit, that AmeriGroup is removing, and I gotta make sure I read this correctly. AmeriGroup is doing a removal of notification requirement for observation level of care. So, summary update. AmeriGroup will no longer require notification from members who are admitted for observation level of care. What this means to our providers is they will no longer be required to submit requests for members who are just there for obs. If a member began their hospital course as outpatient and was later admitted to an inpatient level of care, a copy of the physician's orders for the change of that level of care should be provided with the clinical documentation submitted for the medical necessity review. So just the same as before, when you move somebody from OBS into inpatient, we are still requiring medical necessity review on that. But if a member comes in and goes directly into OBS and is not moving from that point in time, you no longer have to notify AmeriGroup. So that bulletin will be out on the website. So that's something huge that I know a lot of our providers are going to be happy to hear about that one. So then I want to talk briefly about our provider updates that we have going on, our vendor updates that we have going on. Superior Vision will continue as our vision vendor for AmeriGroup. We are also working with this vendor for a potential 2021 enhancement for our ophthalmologists, ophthalmology providers to be effective in May of 21. There are more details for this update that will be coming out shortly. The provider bulletins have been approved and are in process of being produced, and may even be our first ones that hit that email blast. I'm not sure. It may go out right before that. But we are looking for Superior to help out with our ophthalmologists and helping to secure and make for positive our members are getting the appropriate information or appropriate services when it comes to ophthalmology. Our current vendor for pharmacy is Ingenio RX. That took over, that change moved from Express Scripts in October of 2019. There were very, very few issues with that. I would have to say that transition moved along in a very great fashion, and very few disruptions for our members happened on that. Then effective on October 1st of 2020, we moved to Access to Care. as our non-emergency medical transportation vendor. There were a few hiccups right at first, but those seem to have eased out. I'm not hearing any issues from our providers that are coming across, and we're very pleased to have Access to Care join our market and to help support our members in any way possible. So I would like to thank you for joining our presentation today. We will be available for questions and answers at the 11 o'clock hour today, and then of course again in this afternoon. So if you have any questions, either submit them into chat. And one thing that I will also say, and I know Maria has said this also, remember, if you have personal HIPAA information, please do not put them in the chat box. You can reach out directly to your reps. We do have all of our reps, the maps, territory maps are out on our public website, and please reach out directly to them if you have information, because we don't want that in the chat. So Maria, I will stop sharing.
Thank you. Thank you, Sarah Lynn. I really appreciate that. That was a great overview. And what we'll do now is go right into Iowa Total Care. Are you available, Kelly?
I am available. Thank you very much for having me.
Thank you.
Give me just one moment. I'm going to pull up my PowerPoint and get it set up there, and I'll start screen sharing.
Sounds good. Sounds good. Yeah, we had a little rocky start where folks could not hear me in the very beginning, but I think we've got all that corrected, and everybody was really patient. I see a lot of questions out there while you're getting yours set up there, Kelly. Lots of questions to go through once you're done with your presentation. We'll try and answer as many of those that we possibly can. If it's more specific questions, we'll address that at that time as well. And whenever you're ready. I see your picture out there. And again, if everyone could stay on mute, it seems to be working really well at this point. So thank you for everyone staying on mute at this point. This makes it go a little bit smoother.
Oops. Okay. I think I have what I want now.
I see it.
So jumping right in, just kind of a slide a little bit more about Centene and about Iowa Total Care. So we do provide innovative solutions for both Medicare and Medicaid as a company, as Centene, as well as specialty services. Iowa Total Care, we are a subsidiary of Centene, and we bring over 30 years of national experience in the managed care industry. Locally, we do staff over 500 employees in and around the state, and our headquarters are located in Des Moines. We haven't seen them for a minute, but they're still there. And we are also now NCQA accredited. So a little bit about our purpose and our mission. So our purpose is to transform the health of the community one person at a time. Our approach is to use focused, compassionate care and coordinated care from people who know you where you're from. So local people in the areas where you're from. And we do want to focus on whole health as well as focus on the individual. So a holistic approach to that individual health. Our overarching goal is to help each and every Iowa Total Care member achieve the highest possible levels of wellness and quality of life while demonstrating positive clinical results. And how we do that is by integrated care, strong support for service integration of physical, behavioral, and long-term services and support through a high degree of healthcare collaboration and communication. Coordination of care organized member care that requires the involvement of all personal and community and healthcare stakeholders to facilitate the appropriate delivery of healthcare services, as well as continuity of care, driven by relationships between the member health providers and community services to ensure ongoing healthcare management through shared goals and multiple care settings to produce high quality, cost-effective care. So Iowa Total Care provides health care coverage for Iowa Health Link, Iowa Health and Wellness Plan, Healthy and Well Kids in Iowa, the Hawkeye program, and core Medicaid benefits are covered, and all services are subject to benefit coverage limitations and exclusions as described in our provider manual. So some of the exclusions would be like the PACE program, the MFP, dental services outside of services provided in a hospital setting, and then also the school-based services are just a few of those exclusions. So members can find an Iowa Total Care Medicaid provider using our online tool. There's a provider directory that they can look through the providers, and it is updated weekly. Or they can also contact member services at the number on the screen. And member services is open from 7:30 a.m. to 6 o'clock p.m. So some of our value add services and rewards. So we have the free SafeLink wireless phone. This program is offered at no cost to the members whatsoever. Members who qualify can get a free smartphone and up to 350 minutes per month. Unlimited texting is also available. Members are able to apply for this program by visiting safelink.com and using the promo code IA Total Care, or they can call 1-877-631-2550. Another value add service is the Babylon service. So the Babylon service is 24-hour access to medical care at no cost, video appointments to talk with the doctor. So it's more of the telehealth services. And you can get started by downloading the Babylon app from the App Store, and then enter personal information and the code Iowa Total Care. Or you can also contact Babylon directly at 800-475-6168. We also have the Start Smart prenatal and postpartum program for babies, care management to extend the gestational period and reduce pregnancy-related risks. The My Health Pays is a healthy rewards account program. It's an innovative approach to encourage health behaviors through financial, I did not mean to do that, through financial incentives. And then we also have the 24-hour nurse advice line. So registered nurses are available to provide education and triage for complex health issues. So our non-emergent medical transportation is also through Access to Care. And eligible members or providers on the behalf of members may request a ride for medically necessary appointments. Non-emergent appointments should be scheduled at a minimum of 3 business days in advance. So just a little bit about member eligibility verification. So eligibility can be validated in several different ways. You can use the provider portal 24 hours a day, call the member eligibility IVR self-service system, which is also available 24 hours a day, or you can contact provider services through the hours 7:30 a.m. to 6 p.m. if you need to talk to someone to verify eligibility. Make sure that you have the member's name, the ID number, and the member's date of birth to verify that information. This is just a sample of the Iowa Total Care member ID cards. So member grievances and appeals may be filed by the member, by an authorized representative for the member, or by the member's provider. If a provider wants to file a grievance or appeal on behalf of the member, written consent must be obtained from the member or their authorized representative on the designated form, which is located at this link. And the provider manual has more information on how to file the member grievance appeal and state fair hearing, along with details on deadlines. So some provider responsibilities on access and availability. These include, but aren't limited to, making sure that you credentialed, re-credentialed every 36 months, so the re-enrollment period. ADA compliance, including parking and entry pathways. Encourage members to execute advanced directives and remain in compliance with those requirements. Make sure you're billing primary insurance prior to Iowa Total Care. Communication of changes, address changes, addition and termination of practitioners to your group, and other notifications that we may need to be able to make sure everything is up to date in the provider file. Maintaining accurate and complete medical records, and there's more information for that in the provider manual. Rendering medically necessary and appropriate levels of care for members. Ensure access 24 hours a day for primary care providers and specialty providers. Specialty coordination and communication with primary care providers. Non-discrimination based on race, color, national origin, disability, age, sex, religion, mental or physical disability. So the access and availability standards that network providers must comply with would be hospital emergency availability, obviously 24 hours a day, 7 days a week. Primary care physician availability, urgent within 24 hours, routine appointments with the primary care 4 to 6 weeks from the date of the patient's request. Behavioral health for urgent cases within 1 hour of presentation at service site or within 24 hours of telephone contact with provider or Iowa Total Care, and routine appointments within 3 weeks of request. Specialty providers, again, urgent within 24 hours and routine care within 30 days of the member's request. So most common issues for identifying and reporting fraud, waste, and abuse, use of incorrect billing codes, not following service authorization, inaccurate procedure codes for the service provided, and excessive use of units not authorized. And this kind of also goes with the service authorization and for the member side lending of the insurance card. And the numbers listed are for the Iowa Medicaid Program Integrity Unit, as well as the Iowa Total Care Fraud and Abuse line. We're going to move on into claims. So for claim submission, Iowa Total Care does require electronic submission for expedited processing and payment. The only exception to electronic submission would be the individual CDAC providers, and those claims can be submitted to the Farmington claims address listed on the screen. Availity is our preferred clearinghouse for electronic submission. It does offer transactions at no charge, claim submissions 24 hours a day, web-based training and reporting, and customer services open from 7 a.m. to 6 p.m. We also accept transmissions from Change Healthcare and Ability. Other clearinghouses would need to be reviewed on an individual request basis. So just kind of some information on claims and submission timing. So for brand new claims, 180 days from the date of service. Retroactive eligibility claims within 365 days from the notice date for eligibility. For secondary payers, 365 calendar days from primary payer claim determination. And for third-party submission with no reply after 30 calendar days of no reply. claims would be accepted for 12 months from the date of service. So timing on those claims, for a new clean claim that comes in, payment timing is with 90% of claims within 30 calendar days of receipt, 95% within 45 calendar days of receipt, and 99% within 90 calendar days of receipt. For claim reconsiderations, we need those within 180 days from the date on the EOP or the PRA. Quick slide about pay span. So for getting your payments through EFT, we do use pay span. The contact information is listed at the top of this slide. And there are just a lot of different things about pay span that make it easier. You get your claims payments faster, settle claims electronically through EFT and get electronic ERAs. You can match payments to remittance advices quicker. So just a quick slide about the top 10 claim denial reasons currently with Iowa Total Care, and these are in no particular order. Duplicate submission of claims. So if we receive duplicate submission, those claims can sometimes hit at the same time and bounce off of each other and kind of deny each other out. Primary payer, so if there's a primary book prior to Iowa Total Care that needs to be billed prior to billing it to Iowa Total Care. No authorization on file, or the claim doesn't match the authorization. ACE line and claim level, those kind of go together. Some of those ACE line denials are at the line level and some of those are at the claim level, and both of those are things that are being looked at. Procedure coverage not defined by Iowa Medicaid, so the code that's being billed is not defined in the fee schedule. Service exceeded authorized limits. So again, issues with the authorization, not following the authorization. Electronic filing required. So receiving paper claims when electronic filing is required. Timely filing. And then provider Medicaid ID required from Iowa Medicaid. And those would be those war denials, and also something that we've been working on. So wanted to go a little bit about the remittance advice and the explanation of payment. So these guides are available on our website to kind of help understand how to look at the EOP that you receive. So on a clean paid claim, the service line that you see at the beginning, the 0100, that would indicate that this is an original first-time claim. So the first time we received the claim, it hasn't been adjusted or changed in any way. It's just the original claim. If it's a denied claim, it would also be indicated with the 0100, and then you would have the denial codes on this particular one are EF, ES, and EU. Explanations for the codes are also provided on the EOP. If you're looking at an adjusted claim, so the original claim would end in 00. The adjusted claim, so when we do the adjustment, there's a take back and a repay. So the take back portion would be with a 01, and then the repayment section would be with a 02. So you would be seeing the original claim on that EOP for the adjustment, the take back, the adjusted line, and the new payment. Each of those indicated with that service line ending in 00, 01, or 02. So by subtracting the original payment amount, the 01, from the final adjudicated, the 02, you would receive the net amount that you would receive in addition to the original payment. So in this example, a positive net resulted of $15.67. So in some situations, the payment would not change. That would result in a $0 net payment. So you would see that the claim comes in and pays the exact same amount as the original, and that would result in a $0 adjustment. You would still see the different lines on your EOP, just with a $0 adjustment. So in some cases, claims may need to be readjusted under a new claim number due to provider system configuration changes. So if the system configuration changes, we're not able to do the adjustment with the take back and the repay under the same claim number. In those cases, a new claim number is assigned to the claim. In those cases, you would see a JU explanation code with a 0B on your remit. In that case, there would be a brand new claim with a new claim number showing the new payment for the claim. And if you have those 0B adjustments and you would like your detailed crosswalk report, you can contact your provider relations specialist and they can provide you with your full 0B report on the new claims that you're receiving with the new numbers. Moving into claims payment reconsideration, the first step of the dispute would be the reconsideration. Submission of reconsideration request must be within 180 calendar days from the date of the explanation of payment. And then once we receive the review, we would have that completed within 30 calendar days from receipt of all information. If you receive a negative response on your reconsideration, the second step you would have would be an appeal. So the provider appeals must be submitted within 30 calendar days from the reconsideration determination letter. So with those appeals, you want to include as much information as possible above what went with the reconsideration to assist with the determination review. So provider complaints, you have a couple of different options if you would like to file a formal complaint with Iowa Total Care. They can be provided to us by mail at the Jordan Creek location. You can contact provider services, 7:30 a.m. to 6 p.m. You can fax those requests at the number listed on the screen. And you can also contact your provider relations representative and request that a formal complaint be filed. Provider complaints should be resolved within 30 calendar days. Although if there's something that needs to be looked at further, we may request an extension of an additional 14 days. Or if there's more information that you would like to provide and would like to request an extension to provide that information, you can also ask for that extension as well. Just a little bit of information about our provider website. A lot of different things that you can check on our website. There's the prior authorization checker, educational materials, provider alerts. We also provide the COVID information on the front page of our website, and that's updated weekly. We also have the configuration report similar to what AmeriGroup has on their website, which is also updated every Friday. And Iowa Total Care has a couple of different methods to keep providers aware of policy changes. Be aware that we follow policy changes distributed by IME informational letters. We also do training sessions, webinars. You can go to our website, contact provider services, contact your provider relations rep. And we also do bulletins and newsletters, and then also, of course, with our manuals, and we have some guides out there as well. So we also have the provider portal. After registering to access the secure provider portal, these tools are available to you. You can check the member eligibility. Primary care providers can check their patient list. You can view and submit prior authorizations and member health records, view member gaps in care, determine payment and check clear dates, view and print your explanation of payments, access history of payments, submit claims and adjustments and view status of those claims. And then you can also submit claims disputes on the provider portal. And if you have any questions about provider portal, your provider relations reps are a good source of information. And if you would like to request training, a little further on in our slideshow, we do have a new form out there to request training on things like provider portal. Provider services is available 7:30 a.m. to 6 p.m. Providers can access real-time assistance, including claim status inquiries, credentialing and network status, facilitate requests to add or delete physicians to an existing group, Iowa Total Care website review and portal questions, as well as help with registration, facilitate inquiries related to administrative policies and procedures. And also we do provide complimentary interpretation services. So if you have a member come in and you're not able to communicate with that member, a quick call to provider services and we can get you started with interpretation services as well. This is a list of our provider relations specialist territories, and a few slides down we'll go a little more in detail on those territories and who is available in those territories. So moving on to medical management, the department hours are Monday through Friday, 8 a.m. to 5 p.m. You can access medical management by contacting provider services, and they can connect you with them. There is also a 24-hour nurse advice hotline available after hours and on holidays to answer questions about prior authorizations or for notifying community-based case management for urgent LTSS situations. So key medical management care coordination processes include length of stay extension requests. These do require clinical information to be submitted by 3 p.m. on the day the review is due. Concurrent care review, decisions are made within 3 calendar days of receipt of the request. Routine uncomplicated vaginal or C-section deliveries, they do not require prior authorization. However, notification is required within 2 business days of delivery with complete information regarding delivery status and condition of the newborn. Retrospective review requests will be considered in extenuating circumstances or in the case of presumptive eligibility, but the request must be submitted promptly once that situation is met, and decision will be made within 30 calendar days following the receipt of the request, not to exceed 90 calendar days from the date of service. This is just examples of the clinical practice guidelines adopted by Iowa Total Care. And if you would like paper copies of any of these guidelines, you can request those by calling provider services. So care coordination, the care management, care coordination is designed to help members obtain those services needed using a multidisciplinary care management team that would promote continuity of care, holistic approach to yielding better outcomes, discharge planning, and personalized care plans for those members, delivery of quality and comprehensive care services within the community, rapid and thorough identification and assessment of program participants, and especially noting members with special healthcare needs. It is very important for providers to notify Iowa Total Care as expeditiously as possible to the member's circumstances or of any significant changes in the member's condition. So HCBS care management is a person-centered planning approach incorporating the full range of physical health, behavioral health support services that address all of the needs of the members. So case managers engage with the members' team, coordinate services to minimize the silos. Members remain at the center of the integrated care model. So things that they need are coming to them, tailor-made by their team. Qualified provider partners ensure members receive authorized services. They're residing in an appropriate setting, engaged in their community, and have the opportunity to get out there and do what they need to do. And if a significant change is observed, reassessments are made. Some LTSS benefits would include the HCBS services through waiver and habilitation programs, facility services, long-term care, home health services, as well as hospice services to terminally ill members. So on our website, the prior authorization check tool is a very great place to start when looking for authorizations. So you can just enter the code into that tool, and it will let you know if the code requires a prior authorization. And if it is noted that the code requires a prior authorization, a link will appear that allows submission of the request in our provider portal. And if you have questions about that, you can also contact your provider relations rep, and they can walk you through utilizing that tool. So prior authorizations are for medically necessary services. Failure to obtain a prior authorization may result in a claim denial. If there is a required prior authorization, the claim could deny. And remember, members can't be billed for services denied for lack of prior authorization. All non-PAR providers must have all services prior authorized, except for family planning, emergency services, post-stabilization services, and tabletop x-rays. And also remember, an authorization is not a guarantee of payment. So the authorization is looking at the medical necessity. It doesn't necessarily cover if the member is eligible at the time of service. The service itself has to be a covered benefit, and the service must be medically necessary as per plan policies and procedures. Prior authorizations can be submitted in a variety of ways. The provider portal is a good way to submit the prior authorization and be able to track it. You can also fax those in. And if you have questions or need assistance with a prior authorization, you can contact medical management, again, through contacting provider services. The business hours for prior authorizations is 8 a.m. to 5 p.m. Monday through Friday. Any requests received after normal business hours would be processed the next business day. So timings on the prior authorizations. Scheduled admissions or elective outpatient services must be requested 5 business days prior to service. Emergency services, inpatient within 24 hours of admission, and observation within 1 business day of service. Newborn delivery notification, a prior authorization isn't required, notification within 2 business days of delivery. NICU admit within 24 hours of the admission. And the review timings are as follows: standard non-urgent within 14 calendar days, expedited or urgent services, inpatient within 24 hours, and outpatient within 72 hours. And then the inpatient concurrent review within 72 hours. So you can request a peer-to-peer review. It must be requested within 2 business days after notification of denial. And you can do this request by contacting provider services and selecting option 5. If the 2 business days have passed and the peer-to-peer review has not been requested, the provider would need to go through the grievance and appeals process on the member's behalf. So for retrospective reviews, that would apply to authorizations not obtained timely due to extenuating circumstances. For example, the member is unconscious when they come in. They must be submitted promptly, but no later than 90 calendar days from the date of service. And then Iowa Total Care will make a decision within 30 days from the date of request. So NIA is used for the radiology, high technology radiology benefit. Information is listed. Their business hours are 7:30 a.m. to 6 p.m. Monday through Friday, excluding holidays. Requests received after normal business hours would be processed on the next business day. Determinations generally are finalized within 2 business days, although some of those may take a little bit longer depending on what's needed for clinical determination. The authorizations for these are valid for 30 calendar days from the date of request. And if there's an appeal needed for an NIA request, that would go to Iowa Total Care. Our pharmacy prior authorizations go through the involved vendor. And prior authorization requirements can be found on the Iowa Medicaid preferred drug list. Just a little information on prior authorization submissions. The form is available on this website, the Cover My Meds website. You can fax the form to the number listed, or you can also call. Involved pharmacy review timings are 24-hour turnaround time, and in cases where it's needed, 72-hour supply of medication can be made available in the event of an emergency. And again, requests received after normal business hours will be processed the next business day. So earlier I was talking about you can request training or a meeting from your provider services or your provider relations rep. This form is available on our website to go and fill out and request that training. Currently, the training would be available via Zoom, but that training could be available via in-person training in the future. A couple of quick slides on EVV, as already talked about by IME and AmeriGroup. So effective January 1st, 2021, it will be required for CDAC and homemaker services. CareBridge is the EVV vendor. The training is available through CareBridge. CareBridge has sent out surveys, and those must be completed. We also have PR reps contacting providers to make sure that these surveys are done. If you need to do that survey, you're a HCBS provider and you need to do the survey, you can contact your provider relations rep and do the survey over the phone. It is available right now. So we do have some providers already utilizing the EVV platform. And we do encourage providers to start utilizing the process prior to the deadline to make sure that you're comfortable with the process. This is no cost to providers. And then CareBridge contact information is listed on the slide. So just letting everyone know what services require EVV currently. The current authorization process will remain in place, but you will also be able, when you get into that CareBridge platform, to view your authorizations within CareBridge. Just a quick slide on helpful contact information. So some helpful information, our website, mailing address, the fraud, waste, and abuse email and phone number. The options, when you contact provider services, the options to go to different places. So for authorizations, I had mentioned earlier, you would choose option 5. for case management, option 6, etc. This is a listing of the provider relations reps and the territories that they currently assist with. So it will list their phone number and their email address. So Region 12 is actually the Polk County area, and there are 2 reps that are currently assigned to Region 12. Their information is at the upper left-hand corner of this. The leadership for provider relations is on the upper right hand, and then as well as our statewide and out-of-state reps. For provider contracting, some information for the reps for provider contracting by region. And this would be the map for the community-based case management manager regions, as well as the managers and vice president, the directors and vice president listed on this. So just some information for the ITC partners. We partner with vendors Involve Vision and Involve Pharmacy. NIA, as previously mentioned, for radiology. We have the 24-hour nurse advice hotline. Voyance is our interpreter services. And again, if you need interpreter services, you are able to contact provider services and they can get that interpreter services on the line for you. Access to Care, and then as well as PaySpan for EFT. That is all I have for you. Thank you very much for attending.
Thank you, Kelly. I really appreciate all the information that you shared. And now we'll go ahead and go into the question and answer session. So if both MCOs could stay on the line with us in case there are questions for you folks. We'll also have questions and answers from our staff here at IME available. So what I'll do is I'll start with the chat group. First of all, if you have not put in your email address, your name, and who your provider is or who you are as a provider, we will be sending out a survey. It'll be under SurveyMonkey to those email addresses because we would like feedback on these training sessions from you. The second thing that I'd like to say is when I go through the questions here, some of these we might have to ask specific questions as to what your actual question is. So from IME and AmeriGroup and ITC, we'll be able to help answer those just a little bit better. So if you have not signed in with your name, your email address, and the provider name, I would greatly appreciate it if you could put that in there. So at the top of the list, we have quite a few questions, and we do have an hour to answer these. So some of them have already been answered by Mike Kitzman. You'll see some responses in there. For example, someone asked several questions about EVV. And EVV has been addressed by IME as well as our group and Iowa Total Care. But here is a link he's provided in there. It'll also be on our PowerPoint training once it does come out in 2 to 4 weeks. But any information that we have and have presented will be on each one of our websites. So all of this information is readily available for you at any time on all of our websites. So EVV, I believe, has been addressed a couple of different ways. If you still find that you have questions, you can always go to the website, and they do have folks available to answer those questions. So going down a little bit further, there was an individual that asked about a fee schedule, and then down below that question, Mike Kitzman answered the fee schedule page on the IME website. There is a link that he shared there for the fee schedule. Now regarding, is Indian Health Services still an exception to the payer of last resort? So Tawera, don't know if you're the best person for this. Are you able to answer that question? And Mike, are you able to get her off of mute so that she can answer the question? I can barely hear you. There you go.
I'm looking for her. Hang on.
Okay. Or if any other one of our team could answer that question. And then while he's looking for Tawera to answer that question, I see Sherry, you've put in here, we have a lot of issues with AmeriGroup processing secondary when the primary is a Medicare Advantage plan. I don't know if you've reached out to AmeriGroup and your provider representative on that to be more specific. That might be helpful as well to reach out to your provider representative on that particular one. Any specific questions on claims not paying, those I feel like you would get a more direct answer from your provider representative if it is an MCO type of issue.
Maria,
Yes.
this is Sarah. I would be glad to step in on that. As I talked in our presentation, we have a couple of projects for coordination of benefits for that secondary payer that has just completed. And we do have a couple more that are still in process. And I believe that they're shown on that system configuration page. So if you're not getting your answer, if the provider is not getting their answer there, then we do ask them to reach out for the reps. And I did forget to show within our presentation that we do have all of our rep maps out on our public website. Again, in that green box on the left-hand side, there's a drop down that says find your representative. And if you're having issues where a representative is not answering you back, the manager's phone numbers and emails are also listed on that map. So I know that that's a question later on down in the chat, so we can skip over that one.
Good. I appreciate you answering that for us.
You're welcome.
Yeah. All right. And while we're waiting for Tawera to come on board here, it looks like
Hey,
Lisa
Maria.
asked, yeah, go ahead.
Tawera did provide an answer in chat. I believe we're having an issue with her audio due to the number of participants in the meeting.
Okay.
She's not muted. We can't figure out why her audio is not working. But she did provide an answer in chat that said Indian Health Services are always payer of last resort. And then she provided a link.
Perfect. Well, I appreciate that. Yeah. So this is our first time having an annual provider training with so many folks on board. So you're actually a part of a good group to get us started with. So thank you for helping us work through some of these little bugs in here, but I'm glad that she was able to answer that question on chat and actually provide that link as well. So if anybody needs that link, they're able to copy and paste that link right off from the chat, and it will also be in our presentation later on. So moving right along then, regarding, we have had, Lisa says we have been having issues with our home health claims. We do not bill Medicaid primary as they do not meet the homebound criteria for Medicare primary billing. We have got a whole bunch of recoupments saying Medicaid would not pay in this case. Are we doing something wrong? Is that more of a generic question? And Mike, I'm not sure if any one of our team can answer that, or if Pam, if this is a question for you. Pam Lester.
Yeah, sorry, what was the question again?
Sure, that's okay. Okay, we have been having issues with our home health claims. We do bill Medicaid primary as they do not meet the homebound criteria for Medicare primary billing. We have got a whole bunch of recoupments saying Medicaid would not pay in this case. Are we doing something wrong?
Yeah, I remember reading that. And that sounds like more of a home health question versus a health home, because the homebound requirement is for home care versus health home.
Okay. Well, if we're not, go ahead.
Julie from AmeriGroup.
Yes.
You can hear me?
I can hear you.
I'm assuming that probably for AmeriGroup. We did have a large recoupment project surrounding home health. Are working diligently with our cost containment program to kind of see, there may be some that are appropriate because of eligibility issues, but we are reviewing all of those with cost containments. So I know we've heard from a lot of providers that I know you've gotten those. Until we have final answers, we would encourage providers to at least follow the process for if you don't feel that they're appropriate recoveries, but we urge providers who may be nearing claims until dispute the claims with the cost containment directly until we have a final answer on what are appropriate and what not. So we're very aware of all these letters going out and reviewing as quickly as we can to see what's appropriate and what's not.
Okay, is there any action that a provider should take? No. Okay, all right. So you'll make them aware of what's going on as you proceed forward. Okay. Well, I'm glad that you were available to answer that question. Thank you. All right. So then moving on to Dorothy's question, Dorothy Thorne. I have a few ITC claims where they are not paying the Medicaid rate when the private insurance is actually less than the Medicaid rate. ITC is paying up to the primary's contracted rate. Am I correct that these claims should still pay up to the Medicaid rate regardless of private insurance contracted rate? And Kelly, are you able to address that one?
Sorry, I was muted. They should be paying up to the fee schedule rate, not the private insurance contracted rate. And I would ask that you contact your provider relations rep and we can get that put in to see what the issue is.
Okay. And you did provide, both the AmeriGroup and Iowa Total Care did provide a map, and it is on your website as well of how to find your provider representative. So if you do have additional questions before submitting a state complaint to IME, we always encourage you to contact your provider representative through the managed care organization first, and that way hopefully it could be expedited and get you the answers that you need, and working with someone on getting those issues resolved as quickly as possible. However, if for some reason that is not working, you can always contact me, and I did have my email address out there earlier. But getting you in touch and in communication with your provider representative from the MCO, I feel like is going to get you the quickest, most accurate answers. And hopefully that will help you knowing who your provider representative is. Regarding MediShare, there's another question out there on MediShare. Their phone system says that they're always secondary to any other payer. Does this include Medicaid? And Mike, I don't know if Ware is able to answer that one, or someone from our team like Desiree. Mike, can you hear me okay?
I can hear you. I'm just trying to find teammates. There's 400 people, 400 names to go through. So could you restate the question in the meantime?
Sure, absolutely. There's 2 questions out there regarding MediShare, and their phone system says that they are always secondary to any other payer. Does that also include Medicaid?
Well, Medicaid, someone can correct me if I'm wrong, but Medicaid is always the payer of last resort.
Mm-hmm. And that's what we had also in our slides as well. It's the payer of last resort, and that follows any other payers that are out there. And that is my understanding as well. But we'll get some clarification on that and make sure that when we send out the questions and answers and have those questions and answers on our submittal and our link to this training session, that will definitively be answered. But that is my understanding as well. So let's go through the next question. Does this mean IME will stop sending the unverified third-party liability files to the MCOs? And I'm not sure who on our team would be available to answer that one. And if AmeriGroup or Iowa Total Care would like to step in on that one, on third-party liability and sharing those files, we'd be happy to hear from you as well. Because it does sound like there are some issues that have been presented, and that's why we decided to go ahead and make part of our presentation regarding the third-party liability. And while we're waiting for an answer on that one, here's one for the MCOs. How do we get Medicare patients' eligibility records updated with the correct MCO for their secondary claim crossover? I have patients who have MCO and their claims have never crossed over to the MCO or are crossover to the wrong MCO. Would AmeriGroup with Sarah Lynn or Kelly like to address that?
Maria, this is Sarah Lynn. And first of all, I'll address the third-party liability issue that is also happening. We have noticed in the past couple of months that we seem to have some old data that is being applied to some of our records. AmeriGroup employs a company to go out and identify third-party liability for our members. And we update our file system with that, and we're not sure what's going on. I know that our director of operations is working to find out why we've got some old, what looks to be some old third-party records out there. And I don't have an answer on that, but I know that they are currently working on it. So as soon as that is updated, we'll make sure that we put out a provider bulletin or notify all of our providers about that. And I know there's been a lot of it's coming from our cost containment unit. So we are working on that. Again, I will recommend that you address it with your cost containment unit per the letter that you have received, because we don't want anything to go timely that might go to effect. So I can address that part. And now I'm sorry, I don't remember what your second question was.
That's okay. That's okay. So I have patients who have an MCO and their claims have never crossed over to the MCO or are crossed over to the wrong MCO. That was the second part of the question.
Unfortunately, AmeriGroup does not have control as to the identification of those members from the MCO, and that typically comes from Medicare themselves or from Iowa Medicaid. We do notice that there are some members that have not been identified, or they were identified and there's not been enough time and those things are not crossing over. So unfortunately, we try to work with you as much as possible and help you out, but that's not something we always have control over. If it becomes a systemic issue that you think the majority of your members are experiencing that, if you'll let your rep know, we'll see what we can do.
And that does help. The next question is again about crossover claims. Lisa states, I got a letter saying the same thing. We always bill the XB condition code along with XB non-homebound in the remarks field to indicate the patient does not meet Medicare criteria. Now we are getting recoupment notices from AmeriGroup saying that they are taking money back. What changed? What am I doing wrong?
Hey, Maria, Julie again, and that just goes back to it's not necessarily the way it was billed or different directions on how it was billed in the past. So the one piece I did notice on my thing is we are probably, or we're looking at not doing anything with claims that are 2 years older with those recoupments. But again, we'll have more information on that. But it's not necessarily how it was billed in the past for those recoupments, just because the directions had changed over time on how to do that. So any questions regarding home health recoupments would fall into this bucket that
Okay.
providers are getting. We'll have more information on that.
Julie, I appreciate that. Thank you. Kelly, did you want to chime in on anything regarding the crossover claims?
So I did get a response. We also, similar to AmeriGroup, use a third-party vendor to validate the third-party insurance, and we're working through that. And then we also have a process where providers can alert us if there is a third-party insurance that is on file that we're not aware of, so that we can go through, validate, and remove that as well. And I'm kind of with Sarah Lynn on the crossovers. Sometimes it's just a little bit out of our grasp and getting those in there quickly. But definitely it's something that you would want to reach out to your PR rep and have them move it up the chain.
That's a good suggestion there. So we have Genevieve that's asking about, we are still fighting reprocessing NCCI edits. At the beginning of the year, the NCCI edits were revised, allowing us to bill PT treatment with evaluations. But we have been appealing since then and have had multiple recoupments and denials since that time. Now, since October, the edits have been reinstated and our old claims have yet to be reprocessed. Will they address this? And I'm assuming that would be for the MCOs. So I can reread the question if you need me to. Carolyn or Kelly?
This is Kelly. We're definitely working through some NCCI things with our team, and they do take a little bit of time. We also use a third-party vendor with those, and just getting those in place takes a little bit of time. But definitely, as we get those updated appropriately, then we would be doing projects to get those claims reprocessed.
Perfect, thank you. And anything from AmeriGroup on that one, NCCI edits?
Yeah, sorry. Sometimes it takes me a minute to get the answer back from my group and get myself off of.
Okay.
But I want to let you know. Oh darn! I just lost my IM. Got to read this. We have 2 large projects that are up and running, and you should be seeing adjustments in the next 30 days. AmeriGroup is reprocessing those claims at this point.
Perfect. Glad to have those answers. All right, so moving along to the next question here. Marcy states, Lisa and Jessica, you can try, okay, so this is regarding an answer to that. You can try adding an ICD-10 code, a Z76.89 at one time. And the MCOs said that this is a workaround for false denials for missing primary EOBs on claims that are not covered by Medicare. And I don't know if anybody from the MCO side wants to address that or confirm that on your side there, but that is what she's stating, that she states you can try adding an ICD-10 code Z76.89 at one time. They said that the MCOs were saying that that was a workaround. So I don't know, do either one of you want to address that?
This is Julie Maria. Let me go look. We're in the process of revamping our home health claims so that they go through smoothly. I just don't have it in my fingertips. Has any input on that? Again, if it's past claims, the issue was not how you billed. It was these past recoupments. And let me see if I can find the current guidance on the home health claims.
Okay. And then Tuera did put in there the IL informational letter 1711 reviews the HH agency condition codes. There's clarification in regards to the XB on there, and she provides a link in there. And while Julie's looking that up, Mike Kitzman wrote out there that please sign up for the informational letters using the Iowa Medicaid Provider Access Portal, the IMPA portal, and he did provide a link out there. And then responding back to Monique's question, will a copy of the chat questions be made available and those answers? And he states in there that we will answer all the questions posted in our chat. Some answers may take longer to answer, as we're seeing here today, that some of them do need to have some review on those. But definitely the questions that you're asking are very important to us, and we want to make sure that those get out to you on a question and answer session when we get through with this. And Julie, just pipe in whenever you're ready with that one, and I'll continue on while you're searching for that. Is that okay?
I think I have the answer.
Okay.
Edits for the Z7689 in any non-primary position, and again, I'm reading, I apologize. We're in production as of 11/15. And we can use that for any claims post 4/1 of 2020. And we no longer accept the XB, XA through XD codes any longer. That's the new part that we're automating. So after 4/1, you can put the Z diagnosis in any position And you don't have to do the XB. Indicate that on the claim.
Okay. All right. So is there something that you're reading from that they would have access to?
I believe we have a communication. If it's not, it is on the website, and we've sent out this information through the association as well. Back in March.
Back in March.
So it would be on the provider website to refer to. Yep.
Okay, thanks, Julie. I appreciate that. And looks like Monique, you asked, will IME be adding the non-physician telephone codes to the fee schedules for mid-level providers? Medicare added these in June due to the pandemic. And I think that there's some information out on a website that will respond back to your question on when we put the questions and answers out there. There is a link to IL 2113 that Mike Kitzman put out there. And then Sean, there is a question out here, and I think this has been brought up quite a bit. If you could address this, are there plans to add a third MCO?
Yep, we get that question all the time. So federal law requires that there be 2 MCOs. The IME goal is always to have 3 MCOs, but there is no plan right now to be adding a third in the near future.
Okay, so that's always good to put out there for everybody to hear, so I appreciate that. Thank you. It looks like we have, will AmeriGroup be making changes to improve the response to prior auth? Waiting for responses for 2 to 3 weeks poses issues in treatment to patients.
Maria, this is Sarah. Do we know what type of provider this is that came from?
I do not.
Okay. Hold on a minute. I got something coming through.
Okay.
Oh, okay. So the AmeriGroup is currently in the process of hiring more staff for outpatient. They will be starting this month. We understand that there have been delays, and AmeriGroup is addressing the issues.
Okay. All right.
Okay.
So, yep. Thank you for that answer. I appreciate it. The next 3 are really back to back for AmeriGroup. For availability, you can add up to 4 claims with the same issue, either for the same patient or other patients, and I get notice the denial was overturned. However, AmeriGroup is only processing the first claim on the appeal and nothing on the other claims attached. When will this be fixed, since availability training says to submit multiples of the same issue on an appeal? And another person backs that up by saying, we have experienced this as well. We receive no notification for other claims included in an appeal. Only the first submission, and then another one, AmeriGroup is not recognizing the 59 modifier on that's a separate one, I apologize. So on the first 2 ones, do you want me to repeat the statement or the question?
Nope, I'm good with it. So on the appeals, yes, the provider can submit that spreadsheet. We have ran into a few educational issues that we needed to do with some of our reviewers on claims. So if you do experience that you submit a spreadsheet and you only get the first one reviewed, please reach out to your rep. We have a direction to take that to go in through the leadership of those areas and work with them to make for positive that education is provided to those reviewers, that they need to look at all of those, not just the initial one that's listed. So please don't hesitate to reach out to your rep. And again, those maps are available out on our website.
Okay, and then the next three have to do with the 59 modifier. AmeriGroup is not recognizing the 59 modifier on our therapy claims. We're constantly having to appeal these incorrect denials. Are they working on correcting the issue? And then a follow-up, we've experienced the same problem, and when you file a dispute, we get a duplicate claims denial. Follow-up to that, we are experiencing the same issue with 59 modifier on PT claims. Would also like to know the answer to this question. Thank you. All right, so on that 59 modifier, Sarah Lynn?
Hold on, I'm getting that answer on that one also.
Okay.
Patty, if you're available.
Hi, yeah, can you guys hear me?
Yes, we
Yes,
can.
Hi, so my name is Patty Buckland and I'm on Sarah Lynn's team and I'll be presenting the afternoon session. But 59 modifier and 25 modifier, and you're probably also seeing it with LT, RT, and several other modifiers. So modifiers that are engaged in claiming in which would lift an NCCI edit, the big one being that separate identifiable service, which was what 59 and 25 signify. When providers, and this is across all spaces, so PT, medical, whatever, when you guys are sending claims to us, if you are using a modifier that is engaged in lifting an NCCI edit and we can't determine it was appropriate, we have, maybe in the course of the member's episode of care, something looked weird, we're going to deny that. And the only way to lift that is if you dispute with records to support that you were appropriate in identifying that UA, for example, or EKG or whatever was done in conjunction with an office visit, for example, appropriately. So it's not a problem. It's a valid edit. Just because you put a modifier on a service doesn't mean it's always appropriate. We are looking at the evidence for the member, and we're going to want records. So if you have more questions, you can look to our website. We have a provider update that came out in November of 2019 called Coding Validation. That's what this is. And it'll explain what we're looking for and how claims have this edit being triggered. If you have more questions or you want a provider solutions rep to help you, you can reach out to your rep. I serve Unity Point personally, but we have a whole team of people here to help you out. But that's what's happening with those 59 modifiers and 25 modifiers. If you're consistently seeing them come through denied, you're having some kind of an issue with your NCCI edits. So I hope that helps.
You know what, Patty, I really appreciate that explanation and the referral back to how they can look that up on your website, as well as if they have additional questions after they read that, because I have been receiving a lot of inquiries through my desk on the 59 modifier. So that information is extremely helpful, and also the references afterwards. So thank you for that. We do have a few more questions here. How do we bill COVID days to AmeriGroup so that they will pay correctly? COVID days at $300 increase, and then the balance of the days at regular Medicaid rate. DR in the condition code is making AG pay all the days at the increased COVID rate. And I don't know if that's a common issue or if this is kind of a one-off thing, but are you able to address that at AmeriGroup?
I think we're going to, let's see what they need to do. Hold on, I got a message coming through. They need to do. Can you read it? Okay, can you read it? Thank you.
Yeah. So you need to bill the additional $300 for the appropriate days. We will only pay the per diem, and so if you add that additional $300 charge, we will pay you that increased amount. The DR on the, I think it's the DR, on the code is on the claim level, not the it's for the whole month. We can't do it by claim line. That's the way it was set up. So if you bill the additional $300 for the number of days that are appropriate, you will get paid that additional amount on top of your regular per diem. And I'm going to read one more clarifier. If there are 10 qualified days, you bill $300 times 10. You do not bill $30 times 30 or 31 for the full month. So it should be every day is worth $300. And if you have additional questions, I would suggest you reach out to your provider rep. Thanks.
I know that's repetitive, but they really are a good resource because they are extremely knowledgeable in that area. So that helps give a good jump start off from that. We had several questions after that about EVV starting in January and how that's, with everything going on, how that's extremely inconvenient for everything that we're going through. I would highly suggest reaching out to those folks there at EVV and talk through that situation to see if they have considered that or what they're thinking about in regards to everything COVID related, and then starting a new program on that. So there are some more questions on the 59 modifier here, which we have started to address. Here's one: if a patient is OBS and testing such as MRI, which typically requires an auth, is performed, does it require an auth? So for Iowa Total Care, are you able to answer that? Or AmeriGroup, are you able to answer that? Or maybe provide them again where to go get that information on prior auth? Because we have one here for psychological as well. Psychological testing, does this require a prior auth? They've been told yes, and then they've been told no.
So this is Kim from Iowa Total Care, and I'm trying feverishly to find the question. Could you rephrase it again? I am so sorry.
That's not a problem. It's hard to scroll through those. It was at 1022 from Jen Davis.
Okay.
If patient is OBS and testing such as MRI, which typically requires a prior auth, is performed,
Yep.
does it require a prior auth? And then the one following that, psychological testing, they want to know the same answer.
So the question is, if somebody's in observation and they're getting some kind of test and they need an MRI, does that require a prior authorization? And my answer is, I believe yes. The only time it's not is if they are inpatient.
And the psychological testing is the same question. Psychological, does this require a prior auth? We've been told yes, and we've been told no.
To be honest, I would have to look at the individual code and use our code checker. There are lots and lots and lots of codes for that service type. And so to give an educated answer, I'd have to know the code, and then I would look it up in our code checker.
Sure. And do the providers have access to that? So if they need to find out if prior auth is required, where would they go?
That's on our website under providers. I believe it's the third link on the provider section of our website.
And it's also in the slides, the presentation that I just did, it's in the slides, the link to it as well.
Okay.
Thanks,
And
Kelly.
how about AmeriGroup? Where would they find that? I know we've discussed this a couple of times, but I feel like it's on a lot of people's minds on the prior auth. Where would they find that on your website in AmeriGroup?
Our website for checking whether a prior authorization is required is out under the quick reference tools in our Pluto tool. For that MRI, if the member is in observation, there is not a requirement for the medical side. I'm reaching out to find out about the behavioral side.
Perfect. Just kind of a follow-up. I want to make sure that we're addressing as many as we possibly can. We have about 10 minutes left. This is another prior auth, and it's just essentially a comment question. I agree with the user. We're consistently reduced with our authorizations and are told that the adults have max 12 visits per request. This is not reasonable for post-surgical and those with multiple comorbidities. It seems like since the beginning of the year, auth reductions and denials have increased 100%. This does not make sense if healthcare providers are trying to reduce surgical procedures and also dependence on opioid drugs. AmeriGroup should include more factors in the algorithm that they are using. And I guess it's a comment, but it's also something that I wanted to make sure that I read so that you're aware of that. And AmeriGroup, that's something that maybe is a takeaway for something to research. Yep. And
Thank you, Maria.
Absolutely. So, and thanks for the question. I appreciate that too. So we have several that kind of piggyback on that one there. Let's see. For provider reps for AmeriGroup, if our provider rep is not calling or returning emails or phone calls within 2 weeks, sometimes longer, who can we contact for assistance?
Is that question for AmeriGroup?
It is for, looks like, I would say let's answer for both groups, just in case.
Okay, I can do that. Again, as I spoke earlier, our provider territory maps are out on the website under Find Your Representative. And also on that, there is identification of the manager for those areas. And both our phone numbers and our email addresses are there too. So if you're not getting an answer from your rep, please reach out to the manager.
And for AmeriGroup, what is a good turnaround time? Let's say it's an email that's sent. What is a good turnaround time? What is the expectation that we should have for that return communication?
I don't know that they'll have the answer done in a certain amount of time because it really depends on what the complexity of the issue is. But the acknowledgement that an email has been received, as long as someone's not off on PTO or something like that, should be back within like 72 hours saying, got your email, I'm working on it, or if I need additional facts, I'd say that's okay. But we can't necessarily say that we're going to have a complete answer because it depends on the complexity of the question.
And how about Iowa Total Care?
I would state the same thing. Our maps are available on our website, and also the manager information. And I think the response back, again, not an answer to the question, but a response back should occur within 48 to 72 hours.
Yeah, reasonable expectation, at least that they acknowledge that they've received and they are researching or looking into the issue. Just that acknowledgement is extremely helpful. And then once they receive that answer, then they'll work with the provider on resolution of whatever issue is presented. Thank you. All right, so here's a couple of questions or statements, I should say, back to back that I think that we need to look into a little bit further, but I do want to read these. They have, looks like Ann P, they have no insurance when they come in. We help them apply for Iowa Medicaid, and they might not get approved until after they were dismissed. And sometimes Iowa Medicaid changes the coverage to the MCO at the beginning of the next month and backdate it to the previous month. For example, patient inpatient in June, dismisses in June, IME approves coverage late June, and then in July changes coverage to MCO and backdates the coverage to start of coverage and with the MCO. IME really needs to keep the coverage to the first of the month after 30 days to help hospitals get paid. IME does not require an inpatient auth. And then Monique, after that ditto, I submitted this presumptive question last week to the IME prior to the trainings. This is a huge problem. Can IME and the MCOs address this issue? So I think this is one that needs to be brought to the attention of both IME and to the MCOs. Very, very clear on what it is that you're asking for, what the actual issue is. So I'm glad that you did write that in there, and that's one of the ones that will, definitely take away from here as, if there's something that can be done about that and when it can be done. So thank you both for putting that in there. So we have about 6 minutes here. Let's see. Receiving AmeriGroup recruitment letters for claims in 2017 and 2018, stating the state disenrolled member from MCO. Claims should have gone to IME. How are we to get payment for these old claims when at the time of service it's clearly stated that it had AmeriGroup? Any suggestions from Iowa Total Care or AmeriGroup on those?
Unfortunately, Maria, as you know, we get retro disenrollments from members all the time. And instructed by Iowa Medicaid that those members were not eligible for coverage at that point in time with an MCO or with AmeriGroup. And so if they do have to go back to IME, then we've taken the direction, we have disenrolled a member. And then I think at that point in time, the provider needs to work with Iowa Medicaid on those claims.
Yep. And then my guess is, and we can answer this more definitively later, my guess is because it is something that the provider was not aware of and did accurately bill the first time, that they can submit a documentation on that and submit a dispute on that in case they do get denied for timely filing on that issue. So they should be able to work with, like you said, IME claims on those issues. It is unfortunate that we are not made aware sooner than later on some of these, but it does happen, and I think there are processes in place that the providers can take in order to address that issue. Let's see here. It looks like we've got a lot of questions, very, very, very good questions in here. I don't think that there's one that's more important than the other ones. I do see on here that UHC was mentioned, and I know that I have been getting some state complaints from you folks as providers on UHC. If you are not getting a response from United Healthcare on issues, claims, recoupments, any of those types of things, and you've reached out to them, go ahead and email me at mjames@dhs.state.ia.us, and then we can start a state complaint on your behalf for those. I think that there's a couple of questions in there of how do we deal with United Healthcare since they're out of the picture and may have trouble communicating with United Healthcare. So at this point, if you've exhausted all your resources and possibilities with them, please do email me. Again, I am your provider relations liaison, and that communication, I want to make sure that you have resources available to you in case that communication does break down. So at this point, we do have a couple of minutes left, and I just wanted to, we'll get to all of these questions. We'll put it in a question and answer session for you. Once we receive the answers, the correct answers to all of this, once we've done our research with both Iowa Total Care, IME, and also AmeriGroup, we'll put this out on our website and give you all of the resources that we have available to us to help you do what you do the best. And what happened in the beginning of this presentation was you were not able to hear me. And I want to leave you with this thought. Two things. Please, when I send out the Survey Monkey, we take that very seriously. So I would appreciate just, I know it's one more thing to do, but it helps us help you in doing these types of presentations. We will be doing quarterly presentations again once the dust settles, if you will. We will be doing those again, and I want to make sure that we're giving you the information that you need in order to help you do your job and help our members. But I'll leave you with this one final thought. It is a quote. Sometimes the strength within you is not a big fiery flame for all to see. It is just a tiny spark that whispers ever so softly, "You got this. Keep going." And all of you are amazing, and you do wonderful things for our members, and we really appreciate you and all of the questions that you have. And thank you for your time and being our first group to go through annual training through Zoom. All right, have a great day, everybody.
Thank you.